and my dear students, I welcome you all to another session of RAISA DNB online academic activities today. Here we have four topics today. The first one will be infertility and anesthesia by Dr. Muthumani, and followed by major obstetric hemorrhage by Dr. Nikhil from JRH Western Railway. And third will be anesthesia for multiple gestation by Dr. Sai Dikshit from RH Perambur. Subsequently, the adductor canal anatomy indications and significance by Dr. Ammu from RH Perambur. I welcome Dr. Muthumani to take over and continue with his presentation, infertility and anesthesia. Over to Dr. Muthumani.
Yes. So good evening, sir.
Good evening, Muthumani.
Shall I start, sir?
Yeah, please.
Yes.
Go ahead.
So my topic is infertility and anesthesia. Infertility, which is defined as an inability to become pregnant after 1 year of an unprotected and regular sexual intercourse involving a male and female partner, and infertility in male, which is responsible for 20 to 30%, and female infertility accounts for 20 to 35%, and combinedly accounts for 25 to 40%, and in 10 to 20% of cases there is no causes found. And treatment of infertility includes assisted reproductive technologies such as hormonal stimulation, oocyte retrieval, in vitro fertilization, embryo transfer, gamete intrafallopian transfer, and zygote intrafallopian transfer. In vitro fertilization involves the following steps such as ovarian stimulation and monitoring, oocyte retrieval, sperm processing, fertilization, and embryo transfer. And these techniques of using vaginal ultrasound probe is less invasive and associated with higher pregnancy rate, but it forms one of the most stressful and most painful components of the entire assisted reproductive treatment. And role of anesthesiologist in infertility. A proper medical, surgical, and drug history must be elicited along with the proper preoperative counseling to allay the patient anxiety, which can be detrimental for the procedure and hence the outcome. General considerations for anesthesiologist. Such patients are either suffering from some illnesses or on some kind of medications. First, we have to look out for coexisting illness such as tuberculosis, thyroid disorders, anticoagulation therapies, and antidepressive medications, and any medications for the above illnesses and their interactions with the anesthetic medications, and special considerations in morbidly obese patients and patients with severe renal, cardiac, and pulmonary disorders. And anesthesia considerations in that pain, to provide adequate pain relief to immobilize the patient, and it should be short acting and readily reversible with the few side effects. And anxiety, which is another major challenge for the anesthesiologist. Types of anesthesia techniques: monitored anesthesia care with conscious sedation, general anesthesia, and regional anesthesia such as spinal anesthesia, epidural anesthesia, and paracervical as well as pre-ovarian block. And fourth one is total intravenous anesthesia, patient control anesthesia, and last one is acupuncture. Anesthesia concerns are whether the substance enters the follicular fluid, and second one is what are its toxic effects on the fertilization and cleavage and pregnancy rates. First we'll see about monitored anesthesia care. It is relatively easier to deliver, drugs are well tolerated and best suited in daycare setting. General anesthesia. Among almost all the drugs that we are used in general anesthesia are found in follicular fluid. With the relaxed uterus, it became easier for the gynecologist to aspirate even the small ovarian follicles. Unlike sedation, where a contracted myometrial fibrils pose a hindrance for oocyte retrieval. And aim is to reduce the pharmacological exposure to the shortest duration. Drugs which commonly used in general anesthesia are propofol, which is widely used in assisted reproduction, also has an advantage of antiemetic property. A combination of ketamine with propofol is commonly used nowadays. The ketamine with the midazolam combination also found to be a good alternative to general anesthesia for IV sedation. And benzodiazepines, in that the most commonly used one is midazolam. A combination of midazolam plus fentanyl is found to be safer for oocyte retrieval. And in opioids, fentanyl found to have minimal penetration into follicular fluids, and a combination of propofol with the fentanyl or alfentanyl found to be a favorable agents. And nitrous oxide, which is found to have deleterious effects on in vitro fertilization outcome, it deactivates methionine synthetase, thereby reducing the amount of thymidine available for DNA synthesis in dividing cells. And volatile halogenated agents, which also have deleterious effects on in vitro fertilization outcome due to decreased cleavage rates and increased abortions. And bromocriptine, a potent dopamine agonist given before anesthesia, can suppress transient anesthesia-induced hyperprolactinemia and have a positive influence on embryonic development. Regional anesthesia, which includes epidural anesthesia, which forms a viable option but having no advantages over intravenous sedation. And spinal anesthesia, which is a most efficient method for oocyte retrieval by using low dose hyperbaric lidocaine with low dose fentanyl dose. Paracervical block with different doses of local anesthetic with sedation have been used for egg retrieval. Various conscious sedation regimens used along with paracervical block to enhance the analgesia. And the hormonal response to follicular puncture is fully attenuated by regional anesthesia and partially by intravenous sedation. In patient control analgesia, it is an alternative technique of analgesia with higher level of patient satisfaction by allowing the patient to control over their drug administration. Intraoperative patient control analgesia with fentanyl found to have more patient comfort and satisfaction. And lastly, acupuncture, it is a conventional therapy which activates endogenous opioid system by increasing beta endorphin levels, and it also has the additional benefits of providing antidepressant, anxiolytic, and sympathoinhibitory actions. So that's all.
Okay. It's a fairly decent presentation, but there are few points which have been omitted and few points. I think one point is, do you get hyperbaric lidocaine now?
No,
It has been banned. It is no more available. Supposing you mentioned that in your practical exam and the examiner asks you why it has been banned, do you know the reason?
no, sir.
Anyone else? Post BA graduates? Jay Bharti? Any idea why 5% heavy lidocaine has been banned?
Caudal equina syndrome is more commonly seen in hypertension. So caudal equina syndrome is more commonly seen with
Neurotoxicity. They found a lot of cases of neurotoxicity reported from Netherlands after use of 5%, because initially it was only heavy lignocane which was available, 5% lignocane. So they tried to reduce the concentration, thinking that this 5%, which means 50 milligram in 1 ml, is the root cause for all the neurotoxicity, and tried to reduce it to 3%, 2%, and 1%, but the motor blockade was not effective. So ultimately they have to ban it, and now we have only heavy marcaine or bupivacaine which is available, and that can be used. Another important point is it an admission process or is it a daycare process, retrieval of the oocyte?
So daycare process.
It's a daycare procedure. Is it done
Yes.
in the OT or is it done in the outside the OT?
OTs.
The regular major OT where you do every procedure?
Yes.
So something like an office procedure. So it will be a room adjacent to the consultation room of the physician. Okay? So this is done more as a NORA procedure. Okay?
Yes.
Another important point which you have to mention is what is the technique? How do they stimulate the ovary to produce more number of ova? And why do they need so many ova instead of getting only one ovum? Because ultimately one ovum and one sperm is going to fuse and form the zygote.
Yes.
So why do they require so many ova? Okay. So they induce injection hormone called human chorionic gonadotropin (HCG) or gonadotropin releasing hormone (GnRH). Okay. By injecting this hormone, they stimulate the ovary. There are three techniques. One is called long period stimulation. Another is called the short period stimulation. The third is called minimal period stimulation. And one of the important side effects of this hormone injection is
Ovarian hyperstimulation
hyperstimulation syndrome. You never mentioned anything about that. That is a very important point you have to remember. So after you started off very well by defining infertility, what is infertility, how is it defined, everything. Then you mentioned what are all the techniques of correcting this infertility. Then after that, you must say when you start about IVF, that is in vitro fertilization. That means you are fertilizing the ovum with the sperm in a test tube or in the laboratory, not inside the mother's womb. Okay. So for that, first you have to retrieve or get all the ova that is required, and then procure the sperm from the husband, and then make them fuse or get fertilized in the petri dish in the lab, and then grow it to some extent, and then transplant it into the mother's uterine cavity. Okay. Sometimes you can do it in the fallopian tube also and allow it to migrate like a normal pregnancy, where the fertilization occurs at the fimbrial end of the fallopian tube, and then the fertilized zygote or ovum travels down the fallopian tube. If it gets arrested sometimes in between, it will cause ectopia or the fallopian tubal pregnancy also may happen. Okay, and so that also all this process has to be mentioned before you start talking about anesthesia. Okay, and when you say about the anesthesia, you have to mention what are the requirements for this procedure. Even though it is a very short procedure, then within a few minutes, you need a totally immobile patient and patient who is pain-free. These are the two important things. Because they put the patient in lithotomy, examine the vaginal canal, and then through the vaginal canal only they go and puncture the vaginal skin and then peritoneum and go near the ovary with ultrasound guidance, and then puncture the ovary and then draw out the fluid, collect all the oocytes, and then transfer it into the appropriate collecting tubes. So this is the procedure. Okay. So for that, it was originally how was it done? This oocyte retrieval. Now they have standardized. It is a transvaginal oocyte retrieval (TVOR) is the current accepted technique. But earlier, how was it done?
Laparoscopy.
Laparoscopy. They used to do laparoscopy and then go and search the ovary and then puncture it and retrieve it and do it. Then they were making mini laparotomies also before laparoscopy, and finally now they have come to this particular technique. So for that, many centers now prefer to use what is called paracervical and pre-ovarian blocks, which are very, very simple and that can be administered by the physicians themselves. Okay, so these points, and you mentioned in the beginning that this infertility partly due to fault in the woman, partly due to fault in the men. So what are all the causes that male infertility contributes to this, and how do you anesthetize or give anesthesia for that? What are the causes of male infertility? The sperm should not be all right, isn't it? Either azospermia or oligospermia, or the sperms are not motile. So this is the main reason for the failure of fertilization or pregnancy, contributing to infertility. So for the men, you may do a testicular biopsy to find out whether there is actual sperm production is taking place or not. Or sometimes there may be a blockage somewhere. Commonest cause for block of the travel of sperm from the testis to the urethra is varicocele of the spermatic cord. So that is the commonest cause for pressure on the spermatic cord, causing a blockage and retention of the spermatozoa that is produced and not getting delivered. So they may undergo varicocelectomy to relieve that problem, which is something like a hernia repair. So they have to open the inguinal canal, isolate the varicose veins, ligate them and excise them to relieve the pressure so that spermatozoal travel will be elicited. Okay, so these are the points that you have to add to your otherwise fairly well prepared answer. So I'll just share a presentation with you.
Thank you, sir. Any doubts, questions from students?
I will start, not completed. I just